It's point. Yes, I am
That's
sure.
live share.
Tell us when we are live. Huh?
We are live now, doctor.
We are live? All right. So, good evening, everyone. I am Dr. Preeti Kamdar. I am the Secretary of Maharashtra Ophthalmic Society. And it's my great pleasure to welcome all of you to yet one more episode of One Procedure Per Month. The concept was that there are some procedures which need a detailed explanation. And in usual conferences, CME, we are not able to do justice to them. How can we have squint in 8 minutes? How can we have diplopia covered in 8 minutes or 15 minutes? And that's why we have engaged wonderful and experienced speakers for each subject, which speak and they speak on that subject for 30 to 40 minutes. And then we have question answers, which are answered by our expert panelists. So today we have Squint and Diplopia Decoded. And the speaker is Dr. Ashwin Sainani, who is a very experienced pediatric ophthalmologist and a great teacher. And it's important that Squint is taught by somebody who is amazing, and he's one. And after his lecture, then we'll have question and answers, which are answered by our panelists. We again have a wonderful set of panelists, and Dr. Prasad Valimbe, who's a very experienced pediatric ophthalmologist from Pune, Dr. Nikhil Rishikeshi, who is again from Pune, and Dr. Vaijubade, who's from Parbhani, and Dr. Rinkal Fusate, who is from Nagpur. All of them are very astute pediatric ophthalmologists, and I'm sure we'll have a wonderful discussion with all of them. Before we actually start with Dr. Ashwin's talk, we'll have just a 1 minute presentation by Ajanta Pharma, who has been very kind to sponsor this series. Throughout the year, they are the ones who have been sponsoring this. So if you can just please play Ajanta Pharma's video, please, Manjula.
Sure, doctor.
Thank you all. And before we go to Dr. Ashwin Sainani's talk, I would like to introduce my co-moderator, Dr. Pooja Galla, who is also a wonderful pediatric ophthalmologist and very enthusiastic one from Mumbai. So she'll co-moderate with me. And now, Dr. Ashwin, please, if you can share your lecture. You're muted. Huh? You're muted. Dr. Ashwin.
Okay, I will repeat. Thank you, Dr. Kamdar, for that kind introduction and for this opportunity. I thank you. Thank MOS for this very valuable venture. And I'm going to try and go through some basic squint-based, practical-based evaluation techniques. And then I'm also going to touch up on a bit of diplopia, after which I thought I will go into some pediatric squint cases, some things that are commonly seen in any ophthalmic clinic, and then maybe we'll go through their management and discussion, So I'm going to just start with evaluation of a patient with squint. And essentially, when you do have a patient coming in with a history of squint or an obvious complaint, you want to get a few direct questioning about the squint for you to be able to, figure out what you're dealing with. So if you can ask whether you're seeing an in, out, up, down, since when, is it recent, is it uh, associated with double, which is rare in children, but more so in adults. So you're already thinking about whether this is a concomitant versus intermittent, concomitant versus paralytic. So this initial just history about the squint gives you a lot. Onset itself tells you about whether you're dealing with some infantile condition or a more recent one, and if there are any associated complaints like neurological complaints and things like that. So not much about history. I think I want to reach the evaluation soon. So let's just go into examination. So when a patient with squint is walking into your room, there are a couple of things you can see before he sits on your chair. You're looking for if there's an abnormal head posture, which can occur in certain squints to avoid diplopia. Facial asymmetry, again, something known to be there with especially congenital fourth nerves, and any obvious ptosis. So these things will be before you even he sits down. And of course, then examination takes you forward. I won't spend any time about vision and refraction, but that is vital in squint. Essentially, all squints should have initially a subjective refraction. And oh, did I stop sharing? Can you still see my screen?
Yes, we can.
Yes,
We can.
yes.
Yes.
Oh, okay. Sorry, I can't see it though.
Oh.
Just a minute, huh?
Yeah, sure. You want to stop sharing and then
Reshare.
reshare? You
I
want to
don't
do
know
that?
why my screen went. Okay, can you see my screen?
Yes,
Is
yes.
it a full screen?
Encyclopedic
Yes.
refraction. Yes.
Okay, great, super. This works then. Okay, so it's not moving forward. So I might just
Stop sharing and
stop
reshare.
sharing and share again. I'll do
Yeah.
that. Sorry about that. Okay, that's much better. And so, yes, doing a subjective followed by a cycloplegic refraction, especially in children, is vital. Just for example, esotropia associated with hypermetropia, you want to prescribe the full power. Exotropia with myopia, again, you want to make sure you're prescribing even the small myopia. Uh, Treating amblyopia is important. It helps not only in controlling the squint, but you also have to treat amblyopia. So these are, there's a very close connection between refraction, accommodation, and squints. And so getting a good refraction, subjective first is what we practically do. Do a squint evaluation, because you don't want to be checking squint with a dilated or a cyclopleged eye and then go ahead with your cycloplegia. So let's come to the test we learned right in the beginning, which even um, uh, uh, pediatricians or physicians do, just shine a light. And this is performed by asking you to look at a light. If the reflex or the corneal reflex is at the border of the pupil, you're dealing with a 15-degree squint, somewhere in between pupillary border and that is 30 degrees, and limbus is 40 to 45. This is useful in infants or children who are not cooperating for a cover test. Someone who has a very large angle and difficult to put, prisms in front of the eye. Also useful in one eye, suppose is very amblyopic or blind. Again, gives you an idea of, this is giving you an idea of what is the angle of the squint. So like in this picture, you can see the pupillary reflex is just beyond the pupil in the left eye, giving a about 20-degree angle. And as you can convert degrees into prism diopters by just doubling the number. Now we'll come to the most vital test for squint. It's called the cover test. It's not uncover test. It's called the cover test. And it should be performed in any patient to get a lot of information. So it's done at near distance with and without glasses. So actually you should be doing cover test in each eye 4 times if you have glasses. But doing it with, if you had to do it once, it's best to do it with the glasses for near and distance. So when you do cover one eye, preferably if you know which eye is the fixing eye, then it's better to cover that eye. And say we have given a fixation target for distance, you cover one eye, and then you look what's happening in the uncovered eye. Obviously, you have only one eye to look at, and that is the uncovered eye. So don't be confused where to look. When you cover, you look at the uncovered eye. If you see a movement, you're dealing with a tropia, which means you're dealing with a manifest squint. And of course, you'll be able to recognize whether it's an exo, ESO, hypo, or hyper. Now, the next half of the test is actually uncovering the eye. So when you uncover the eye, now you're only keep your attention on the eye you're uncovering. So sometimes you cannot look at both eyes at the same time. So you want to pay attention to the uncovering eye. So if you didn't have a movement on the cover, but you had a movement on the uncover, you're dealing with a latent squint, or what we otherwise call a phoria. Okay, so cover and uncover gives you an idea or helps you differentiate or diagnose tropia versus phoria. Okay, now when you do uncover, you're leaving the patient with the option now that both eyes are open, to choose which eye that he wants to fix with. So if the patient each time on uncover chooses always the one eye to fix with and gets the other eye to go into squint, you also get an idea of the preference of eye. So when you say a patient has left exotropia, you're actually just saying that he prefers to use his right eye, and his left eye he prefers to let go into the squint. So it's just when we say left exotropia, it doesn't mean that they don't alternate undercover. They will always alternate undercover, but it's a preference of using one eye when you give a laterality to a squint. And then comes the alternate cover test. In this, you go do a cover, and then you don't uncover but go into the other eye, and then back and forth. Now, this test is actually more dissociating than a cover test, which means it breaks down fusion much more. So it reveals the underlying phorias, and thus this test gives you the whole squint. So if there is phoria, the largest phoria will be revealed. If there's a tropia and phoria, the tropia and phoria will be revealed. So this alternating cover test is best to measure the squint. So prism cover test to measure is done with alternating. So let's see some videos now that I have described it. Course, why would this yes, this is playing very good. So he's covered the left eye, and you see the eye was out and it came in, and you covered the right eye, it's coming in. This is looking like phoria, but now when we cover for long period, you see the phoria is building up on the alternate cover test. So this is alternate cover test showing you how you can build up a phoria, because it's more dissociating than just a cover test. Okay, now we'll try and go to the next. Doesn't want to go to the next slide. Give me a moment. Okay, here we go. This is the next one. So this is again in a patient that you can obviously see already has a squint. So you know that there is a left exotropia. And the right is the fixing eye. Sorry, I'm just trying to get this video to run.
If you just click, what happens?
Yeah, it's just something's running really slow for some reason. But yeah, I've got that. But the video has to start.
Is the play on the other side?
No, it's right here.
Volume.
But it's it just seems to be wanting to go slow for some reason. Okay, so what I might do is
So you want to see if you can go to the image or the screenshot of where it comes when we move forward.
But it's not moving, I think. You want to reshare and then is it moving in your is the video playing in your PPT?
Sir, you're muted right now.
You're muted. You're muted.
So we'll show it to you like that. We'll go through the videos on non. You can see what I'm showing you. Yeah.
No,
Okay.
No, we are not able
We
to.
can't see you're
You
not
can't see.
sharing the screen or PPT.
Whichever screen you want to share, you'll have to share it.
Okay.
If it's on iMovie, then you'll have to share it on.
So what are you seeing actually then?
Just
Nothing. We
view.
can't see the presentation. It's
Yeah,
just a view of all of us.
Are you seeing the presentation now?
No.
Okay. Sorry about that.
You have to share whichever screens are open. When you start, when you click share, it will show you the options. So those screens will be able to share with us.
I don't know why it stopped sharing. Okay. So
Now it's saying that you're sharing. Yeah, we can see
Now
the.
just treat the video like this without going into.
yeah, that's what I was
screen.
doing before, but I was somehow not I stopped sharing for some reason. Now you can see the.
Yes.
Yes, we can, but it's not running.
Yeah.
Yes, now it's running.
So in this patient has a manifest squint already, and covering the other eye fix, and we're again dealing with some issues with it. So I might just move ahead. Somehow my computer is running
The
slow.
Wi-Fi is okay.
Yeah, I've got full signal on the Wi-Fi, but it should at least play on my screen. It's, I mean,
True.
yeah. I'm so sorry. I don't know why it's happening.
Along with that, I think the videos also become lazy.
True.
Say again.
He said, along with the eye, the video is also becoming lazy.
Yeah. True.
So I've got a frozen screen. I'm so sorry.
You want to go to
Give
the
me a
next
moment.
slide? Yeah.
Ma'am, I think his even his screen
Yeah.
is stuck.
Like my
We can't
screen
even
is
see more.
frozen.
Yeah,
Like,
you're frozen.
You know what I'm saying?
Actually,
Yeah.
I think you have
You can
selected that this thing, so you just come out of it. The click on the outside of the screen because you have selected that video.
No, but even Dr. Sainani's the
He's
screen is
also frozen.
Yeah.
Yeah, you can hear me, but everything on my screen is frozen. So I'm just
Do you
going
want to share your PPT with one of us? And maybe we can share it and then you can keep talking.
Good idea.
We can share it from our laptop.
Pooja, yeah. Pooja, can you share?
Yeah, you can put it on WhatsApp also or email. Either ways is okay. I'll send it to you.
But if the video sizes are too big, it may not be that easy to transfer also.
Yeah, no, I think we can move ahead, even if we can do it without the videos. It's also a fair thing to do.
Sure. So you can go on to the next slide because now we are no longer frozen, so we are fine.
No, actually, I'm still frozen.
No, we can see you now.
You can see me?
Yeah.
Yes.
Moving?
Yes, we could.
Okay, but somehow I can't see anything.
Oh my.
So I'll just.
You want to log out and then log in again? You want to do that?
I might just have to log in from another device because it looks like this computer is showing me a blank screen.
Okay.
I cannot see you all, but I can hear you.
Okay.
No, but right now we can see you properly, Dr. Ashwin.
Yeah, but
I
I
think he's
understand.
not able to see anything on the screen. He may not be able to mute or
go ahead at all.
stop video or get out. Are you able to exit this?
No, I'm even pressing Control Alt Delete and it's not taking me anywhere. So I'm just going to go to another
Device? All right.
device. Yeah.
So one
Oh,
idea.
no, you know what? Even if I
Have this
go to
on your
another
drive.
device, this computer has the presentation and it's not there on any other.
So if
Do you
you
have
can
it
just
on the
send it to
drive?
Pooja.
On your phone drive or something? If this is on Google Drive, it'll be there on your phone drive.
No, I don't have it on a drive. It's only on the computer. And
Just
so why don't I just shut this computer and put it on? You'll have to just give me that much time.
sure. So in the meanwhile, what we'll do is
Yeah, why don't you all take
there's
some of
some
the
questions
questions that had come?
exactly. Yeah,
That would be a
the
good idea.
questions. Yes.
I'm so sorry. I can
No, no,
hear
no.
you, but I can't see anything. So I'm just going to go in and come out again.
Yeah. Do what it takes.
Not a
And
problem.
Yeah.
we'll take the answer
Yeah.
In
questions.
case the
Yes.
Ajanta people can just log him out.
Yeah.
Because
And just one thing, if you can, your presentation, if you can send it to Pooja via WeTransfer, even large files will be able to transfer, then she can show it. That is the last case scenario if that happens. Again, Dr. Ashwin is
he's frozen.
He's
Yeah,
frozen.
now he's
So no
frozen.
matter, let's, Manjula, if you can just take his screen off, is it possible?
I'm doing it, ma'am.
All right.
So, ma'am, I think we can start with the questions which
Yes,
are
I think,
not
yeah,
related to the examination bit,
yeah,
so that it's unrelated.
true. So what we can do is now management at different age. Okay, so there were first is like diplopia charting. Now, Dr. Prasad, one thing is what is the role of Botox in one of the questions is what is the role of Botox in diplopia? So
Okay, good.
yeah, that is one of the questions that people have asked. So is there any role of Botox?
Yeah, it has. Am I audible?
Yes,
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 sir.
yes. We
Yes,
can
yes,
see you
yes.
also. You're audible also.
Yes, sir.
So it's basically a sort of, I would say, little limited role because we need to find what is the exact cause of diplopia. That's the in the first place. Many of the times we give Botox in cases of some intractable diplopias, sometimes just to tide over between till the diplopia resolves on its own, or many times in the paralytic strabismus. Sometimes in thyroid ophthalmopathies also we do give Botox, but usually I would say it has got a limited role in the treatment of diplopia. Main treatment I would say is treat the basic cause. That's I would say.
Okay, so when you're saying that, Dr. Vaishbade, when would you give Botox? Now, Dr. Prasad has already said that he will give it in certain conditions. So, in which muscle? For example, it's a paralytic squint, it's a left lateral rectus palsy. So, which muscle would you give it, and when would you give it, and
Yes,
what is the dosage?
in cases of lateral rectus palsy, suppose it's lateral rectus palsy, then we will give Botox, say within 3 months to the medial rectus. And we know that Botox effect wanes off within 2 to 3 weeks sometimes, or may few cases if you give more than 2 doses, then we can get it up to the muscle right up to say 3 months. So
Okay.
if the diplopia is intractable and patient don't want any these things, surgery or anything, then we can go ahead with Botox to time being.
Okay.
That is the only rule.
Yeah. Dr. Wrinkle, you are muted. So
Yeah.
in the acute phase, say a person says, and it's a diplopia is really disturbing to that patient. It might be a small amount, but the diplopia is disturbing. So if the person wants to carry on their normal activity, so do you give it in the acute phase, Dr. Wrinkle?
See, diplopia, first thing, the first most important thing will be to diagnose what that diplopia is because of. That's the most important thing. Because acute onset diplopia might not always be a single muscle palsy. So if it is a third nerve palsy, it will be difficult to tackle it with Botox. because obviously many muscles, many extraocular muscles are getting involved at the same time. In simpler single muscle palsies, yes, the other muscle, the antagonist muscle, can be infused with Botox, and it is recommended that it is highly recommended that in paralytic strabismus, Botox use is highly recommended.
Okay, so even in the acute phase, so that the person can get on with their normal life. Otherwise, they are not able to do anything. They have to cover that eye and
We
get
need to
along.
do
That's
something
what
for
will help.
diplopia, either by occlusion or by prisms or by Botox.
By Botox. Wonderful. Oh, Dr. Nikhil, any thoughts on this?
Yeah, in fact, Dr. Preeti, the
Hmm.
Botox will work only in the acute phase. It will not work once the palsy becomes chronic. Because
Okay.
till then, the antagonist muscle, for example, you said the left lateral rectus, the
Hmm.
left medial rectus is going to become so tight and fibrotic in 2 months or 3 months because of unopposed action
Hmm.
that it will become difficult to weaken it even with Botox if we give it after 6 months.
Okay.
Having said that, the initial phase, first 1 month or 2 months, are going
Hmm.
to be miserable for the patient because it's a completely alien feeling of
Hmm.
having a constant diplopia. If a person is a working patient, a
Hmm.
diabetic patient who gets a microangiopathy and
Hmm.
microvasculopathy at the age of 50 and 55, it's going to be so miserable. So that is the time to give Botox. Try to alleviate the symptoms.
Hmm.
The diplopia is not going to resolve in the first 6 months. It is not. It doesn't go that fast. But you may see excellent prognosis in younger patients, provided the generally it's the diabetes, microangiopathy. So if you can control that in the first 2 to 3 months, it can become less miserable. That is the time that the Botox will help most. And you can't even operate them for the first 6 months, right? You have to observe.
True, true, true.
So,
So,
so yeah, I
Convergent
mean,
spasms.
yes.
sorry.
Sorry?
Even convergent spasms, those are like cases who will
Oh yeah,
really
oh
benefit
yeah,
with diplopia.
absolutely,
Sorry,
absolutely.
Botox, I mean.
And they are
So,
increasing by the
Yes, yes, definitely.
hundreds. Yeah.
I
so
would, ma'am,
yeah.
just
Yeah,
like to ask the panelists with respect to this one question, that when you all give the Botox, is it primarily going, do you all tell the patient it's going to get rid of the diplopia altogether, even in this acute phase of the nerve palsy, because you may not get the exact effect and the
Not,
patient may still have
not,
some diplopia
not
after that?
absolutely altogether.
Yes.
It's a temporary measure and it is going to stay temporarily. And because his diplopia also, we expect that it is going to be a temporary problem, right? Like eventually we expect the microangiopathy muscle to get recovered, that nerve is going to get recovered. So that should be like clearly explained to the patient.
Correct.
and sometimes you may have some ptosis because of the extravasation, so you need to tell it to the patient. Otherwise,
Yeah,
the
yeah,
patient tells, "I come for the diplopia and you're causing ptosis." So
absolutely,
I
absolutely.
think
And maybe the
that
ptosis
needs to
will
be
reduce
told.
the diplopia.
I know.
Yeah, yeah.
Natural
That too.
occlusion.
Yeah,
True. That's so true.
that can
Dr.
be a smart answer that we can give, Dr. Pooja.
Yes. ये तुम्हारा
Yeah, you're
फायदा
right.
हो गया.
अब फायदा हो गया.
Dr.
Blessing
Ashwin,
in
So we
disguise.
can see
it's
you
true.
now.
Yeah. Dr. Anaga is here. Anaga, she was traveling and that's why she could not join us. But Anaga, are you there?
Yes,
Yeah,
yes.
she's the
Hello. Hi,
president of
everyone.
Maharashtra Ophthalmic
Hello.
Society.
Hello.
Yes, yes. Just landed. Yeah,
Yeah.
yeah,
Oh,
So
yeah.
good.
nice to have you with us
Great,
here.
great.
Good evening.
Yes,
Good
yes.
evening.
Great, great. Yeah, I'm here. Yeah. Continue the conversation.
Yeah,
Great.
sure.
Great.
So I'll start. Dr. Ashwin, if you can restart with
Yeah.
our fingers crossed.
Yes, we'll do with fingers crossed. Okay.
Yeah. Eyes crossed, fingers crossed.
So I've decided to share screen
Yes.
rather than share the presentation. So
Mm-hmm.
and so essentially this was what we were trying to show you.
Mm-hmm. The
Again,
video.
So this
video.
is the JPEG, it's an image.
You're right, it is.
It's the cover test video, yes.
Okay, so here we have the like we can see that the left eye is the eye that he is a non-preferring eye, and it is the right eye that always wants to fix. So if we have a constant squint and we are doing a cover test, this essentially confirms that he prefers the right eye, and this is now an alternate cover test, which will help us. He has some preference of fixation of the left as well, as you saw. So this is just how you would do a cover test in a patient. We'll do one more cover test where the control. So this patient had very poor control of squint. As you can see here, he has fairly good control. Every time you leave the cover, he comes back and he controls even without blinking. Now, when we remove the cover, you see the eye, it comes back. And so this is a patient with much better control. So you can, in the cover test, when you remove the cover, it also gives you an idea of how well he is controlling the squint. Similarly, in a case of esotropia, also here in this child, you're seeing that she has a constant esotropia, and when you cover, she fixes with the left, but as soon as you uncover, she comes back to the right, telling us that this is a case of left esotropia, which is a constant one, as opposed to the previous case, which was an intermittent squint, which the patient was controlling quite well. So this is important, especially in intermittent squints, to let them go and to see what their control is. So let's now come to the next, which is the measurement of the squint. So as we had discussed, alternate cover test will help us measure the squint. The prisms we have should be placed with the apex of the prism pointing towards the squint, and then you do an alternate cover test. It is performed at near, it is performed at distance as well. And the prism is supposed to be kept in what we call a Prentice position. A Prentice position is such that the surface of the prism that is close to the eye should be in such a position that the vision goes through that surface perpendicularly. So that is what a Prentice position is. So prisms are calibrated in Prentice position, especially the prism bar that we have. And so that is the one that we should place it like that. So this is the prism. Let's see if this plays. Of course, it won't play because prism bar cover test, as we know, is used to measure the prism, measure the squint in prism diopters, which is double that of the degrees. So here, again, we place the prism with the apex towards the squint and keep on increasing the prisms. As you can see, this is an exo. We're kept with apex outside, base inside. And as we increase, you find that the squint is getting smaller and smaller. And if you find that, okay, I've reached the maximum of the bar and still there is a movement, then you can even move to slightly higher loose prism. And if not, then you have to split the prisms. And you can split it with the help of, your own hands, or you can even do it by giving your assistant. So now you'll see on alternate cover test, there is no movement. And that tells us that we have reached an endpoint. And you can add the two prisms. In fact, adding these two prisms slightly underestimates your squint. You have a chart that tells you what the actual measurement is. Okay, so this is the prism bar cover test. Now we'll go on to another test called the Krimsky's test. Now this is performed just by placing the prism in front of the eye and doing a Hirschberg test. So just you can see by placing a prism, the corneal reflex has to be adjusted to come into the center of the pupil, and then that prism is the measurement of the squint. This is very useful when you have uncooperative children who do not want you to do a cover test, and also when you have an eye which is not seeing very well, or a blind eye, and you want to measure the squint for surgery. There is one more test which I thought I'll cover briefly. This is a 4 prism diopter base out test. used to diagnose microtropia. Now, you will often come to a situation where you have a patient who has 6/6 vision in one eye, 6/9 vision in the other eye. You look at the anterior segment, posterior segment, everything looks normal. There is no refractive error, and you're almost inclined in these patients to do an OCT of the macula because you feel something's wrong in the macula. Why is one eye not improving? I don't find any reason. So you must suspect microtropia in this situation. So this is a test for detecting a small squint in which you place a base out prism, as you can see here. And because you placed a base out prism in front of this eye, the image that this eye sees will move towards the apex, which means this eye will move in this direction, as you can see with the arrow. Because of Herring's law, even this eye will move in the same direction, albeit briefly, and then this eye will realize, oh, there is no image there, but the image is straight ahead, so it will move back. So these three movements, both eyes moving towards this way and one eye moving back, is a normal response. But in a case of microtropia, if you place it in front of the microtropic eye, there will be no movement. And that is an easy way to pick up microtropia. Put the 4 prism diopter, which is there in every refraction set. Just place it in front of the eye that is seeing less. And if there is no movement, you can be sure that this patient has less vision due to amblyopia secondary to a small squint. This is a strabismic form of amblyopia. After that, in squint evaluation comes extraocular movements. This is usually done with a torchlight and done in all 9 gazes. You're looking for underactions, overactions, patterns. And this is a good time to even ask for diplopia when the history of diplopia is there, because you're anyways going into all gazes. You're sort of doing a quick diplopia test, not measuring it, but a quick diplopia test. So just like you have gone through extraocular movements, you can even measure the squint in 9 gazes. Now, this really is useful in patients in which you do have an concomitant squint and you're not sure which muscles to operate on. This is a great test to tell you. If you have maximum squint measurement in a certain gaze, you know which 2 muscles are acting in that gaze. You need to operate on one of those 2 muscles. So this sometimes helps us isolate which are the muscles that need to be operated on. These are all tests which we did were versions. Then doing ductions is vital. That is uniocular extraocular movement testing. This is actually quite important to note overactions and underactions. Do not forget to check vergence, which is mainly convergence, the near point of convergence, and saccades. So extraocular movement video, not so vital. We'll move to the next. Now we'll come to some sensory tests. So I'm going to talk to you about the commonest test available in all of our clinics is the Worth 4 dot. You can have 4 responses. Look to the top right side. If the patient sees all 4, that means he's got good fusion. If he sees 3, it means the red eye is suppressed. If he sees 2 red, it means the green eye is suppressed. And if he sees more than 4, he's got diplopia. So this is actually best done in the dark. It can be done for near and distance. And it is something that gives us an idea about suppression. Some of the other tests that we have 2 more subjective tests, which are very, very informative in patients with concomitant squints, mainly those who are suffering from, concomitance or different squint angles in different gazes. So maybe I thought I'll go into it a little bit just to give you the basis of it. So diplopia charting is, mind you, these are subjective tests. So often I don't rely so much on these. I do rely more on doing a 9-gaze prism measurement of squint because that does not require any subjective responses. You're actually measuring a motor like a subject, an objective squint. In any case, diplopia charting, essentially red, by convention, red in front of right, green in front of left, and you show them a linear light, which can be a streak retinoscope, or it could be even a torchlight with, a little patch with a slit in the middle. And you do this at a distance of about 2 meters. Don't have to be very close to the patient. About 1.5 to 2 meters is a good space to do it. Of course, the patient does not move his head when you're doing it. Now, these are some of the responses. It is drawn like this in a little square, cross pattern. And as the patient will tell you, I can see red and green, and he'll show you distance with his hand, and you have to report it exactly the way the patient is seeing it, which means if you're drawing it on the right side of your paper, that means the patient is seeing it on his right side. So that's how we report it. That's number one. Number two, by convention, if he's wearing red on the right, and if his red bar is on the right side of the chart, that means he has got uncrossed diplopia. And if his red line is on the opposite side of the eye that is wearing red, that is crossed diplopia. So that is another thing to detect right away. So whenever you have a medial rectus abnormality, or the patient is in exotropia, then you are dealing with a cross diplopia. It's easy to remember. Exo has the word X in it, and that's why cross diplopia. Esotropes will have uncrossed diplopia. These are for the horizontal charting detection. If you've got a vertical squint, then what you need to remember, it is the opposite of Hess charting. The eye that is up will have the image down. As you can see here, the red image is down for the right being hypertropic. So some examples with the answers given. As you can see, this is a right sixth nerve. Its sixth nerve, the patient presents with esotropia and so has uncrossed diplopia, which means the right image is the red image, and it is on the right side of the green image. So you can see the maximum separation is on the right side where the lateral rectus is functioning. This is an easy diplopia chart. This one is that of a third nerve palsy, a little bit confusing, but what you want to understand is in the right third nerve, when the patient looks up, the right eye doesn't go up, so it is hypo compared to the other eye, and so the image of the right eye will be hyper. So you can see that when he's looking up, the red is up and the green is down. Likewise, when he's looking down, the right eye doesn't come down, so the right eye is lagging behind, and so the image is on the opposite. Likewise, when he is turning to his lateral rectus side, everything seems to be okay, but when he's moving to his medial rectus, he's coming into action, he's getting a cross diplopia. As you can see in the horizontal, the right or the red eye is on the opposite side. It's on the left side. Here, the red stick is on the left side. So a little bit confusing, but I think if you can understand crossed from uncrossed, that will give you a lot of information on what's happening. And this is superior oblique. Let's see, in a left superior oblique, imagine we're looking, where is the left superior oblique? If you can see my face, I don't know, it's looking towards the right and down position. Your left superior oblique will come into play, and that's right and down position. That's the maximum separation. And a superior oblique, when paralyzed, the eye is always hyper. Okay, so in this case, the left eye is hyper. The left means the green stick is hyper, and that's why it's showing below the red signal, because as we said before, if you've got a hyper eye, the image comes down. Hypo eye, the image comes up. I hope I could explain that in some clarity, but let's move on to Hess charting. Hess charting, again, works on the same principle as as diplopia, it's a haploscopic principle, which means one eye sees different thing and the other eye sees a different thing. So you've got this sort of a chart. This is done at 50 centimeters, and you may be aware there are red lights, and the patient is given a green light in the hand. So the eye we're testing is the eye in front of the green light, because that's where the patient puts a mark, and that's what is plotted. So let's see some simple Hess charts. So first, let me tell you some 3 points on how to read a Hess chart. The 3 points are: one, you need to find the chart that looks smaller. That is the eye with the problem. In this case, it looks like the image on the right is the one with the smaller it is, which means that the right eye, in the right eye has a green filter in front of it, and that is the eye that's being tested, and that is the eye that's showing the smaller field. So once you have the smaller field sorted, you try and look for which muscle is underacting the most. And in this case, it seems like the superior oblique is. As soon as you see one underaction, you start looking at the antagonist of that muscle, which is the inferior oblique. If the antagonist is overacting, you have to start thinking of this is possibly a nerve palsy, because these are the natural muscle sequelae we're talking about. So then after seeing the antagonist, which is the inferior oblique, you look at the yoke muscle of the superior oblique. That is the inferior rectus. That should be overacting significantly because of Herring's law. So Herring's law, yoke muscle acting a lot. And likewise, there's an inhibitional palsy of the antagonist to the yoke. So these are all muscle sequelae, right fourth nerve is the diagnosis. Very typical looking picture. Let's look at another typical one. Again, which is the bigger one? It looks like the right is the bigger. We are looking for the smaller, and that looks like the left. So the left one being the smaller one somehow is wrong. It is the right eye which is the abnormal eye in this. As you can see, this underaction is far more than this underaction. And so this is the eye of concern. Just because the lateral rectus not pulling, the antagonist is overacting. Because of this not pulling, we have the yoke muscle overacting a little bit and the opposite muscle of that underacting. So these are the muscle sequelae. It looks like this is not an acute sixth nerve palsy, which is why these muscle sequelae have, become more concomitant. And that's somehow, this is what tells us whether you're dealing with an acute palsy versus a chronic palsy. And let's look at a third nerve. This is the smallest one is this. It looks like the left eye has a third nerve. Again, the lateral rectus seems to be acting well. There's no medial movement, and there is no elevation, no depression. And this is all overacting. So these are some of the obvious muscle. We have a few, and I wanted to put one point across here. This first one is again a fourth nerve. Okay, we did that already. This second one is a bilateral sixth. As you can see, not only this muscle is underacting, this one is also underacting equally with the antagonist overacting. Now, the example 3 and 4 I put here because I wanted to tell you all the third point of Hess charting, differentiating a paralytic from a restrictive squint. So in paralytic squints, we see all these muscle sequelae. In restrictive, we don't. In restrictive squint, what we'll find is the field is rather compressed. It is not expanding in the antagonist level. So you can see this is the smaller field, and that is in the right eye. We see that the elevation is restricted or limited, and you see how it is compressed. Not only elevation, you can see that this not going out of the chart. So this is a case that does not have sequelae like muscle sequelae that we see in. So the antagonist is not going out of the chart. This is looking like a compressed field. This is actually a case of inferior rectus entrapment where the eye is not moving up, or restrictive squint. Restrictive. Likewise, this is that of a Brown syndrome, where the inferior oblique seems to be underacting, but there is no overaction here. And again, this eye is showing a restrictive type of picture where the muscle sequelae are not visible. A couple of tests more. Maddox rod. This is serrated, sort of cylindrical colored lenses placed in front of one eye. Other eye looks at a point source of light. This eye sees that point source of light as a red line. And then again, you ask the patient, how far is this image from this image? What we're actually doing here is we're again dissociating the eye, giving a different image to this eye and a different one. It's like a cover test. So we are eliciting a phoria. We are breaking the fusion. And so phorias are measured with Maddox rod. But again, a subjective test, mind you. Subjective tests are always our second choice. I would better test a phoria on a cover test, and I would better measure it on a prism. So vertical as well as horizontal phorias. And torsional phorias can be done by putting two Maddox rods in front of one white and one red. And then you ask the patient to use his hands to tell you how much is the tilt, and you can actually turn the Maddox rod and make it straight, and that can measure torsion. So double Maddox rod is quite useful because you can't do that with prisms, and you can measure the amount of torsion. Finally, coming to our stereopsis tests. Now, these are important, especially in patients who have intermittent squints. So intermittent squints can have stereopsis. If the squint is constant, unfortunately, you will not have much of stereopsis or any. In this, I want to just say there are many tests to choose from, but if you had to buy one, it's better to buy either the TNO or the Frisbee, because these are the two tests that does not have any monocular clues, which means no matter what you do, without those glasses, you'll see nothing there. And you know, especially in patients who you keep measuring again and again, you want something like this. And they can measure all the way from 15 seconds of arc to 2000 seconds of arc. And so these are valuable tests. This Langs is without any glasses, and so good for babies. And of course, Titmus is, you know, the first test that came out. So I thought this is ending, you know, our examination of a squint or evaluation of a squint. I thought I'll just touch on approach to diplopia with just a few slides, not in very detail. I just thought that when we have a patient walking in and giving you a history of diplopia, you're obviously thinking immediately of cranial nerve palsies, but you want to get some history to make sure you're dealing with diplopia and not just blur. You want to know whether it's monocular, and if it is monocular, then it's not due to a squint. You also want to know whether it's recent, long-standing. One question that I ask always and make decisions of treatment based on it is it bothersome or is it ignorable? You know, so that will tell us how hard you have to hit the treatment. It also helps to know which gaze, which distance, which time of the day it's coming. And if the patient says he has vertical diplopia, but he has no obvious incompetence you can see on extraocular movement test, then you should suspect a fourth nerve palsy, because fourth nerve palsy is patients on examination with, before you do your cover test, you'll feel, oh, this is normal, because his movements will appear completely full, almost full, unless you go looking for those overactions and underactions. So suspect fourth nerve when there's a history of vertical diplopia, and otherwise the eye movements look fairly normal. Yes, I was telling you about bothersome and ignorable diplopia. So you see, if the patient says, I cannot read, I cannot watch television, I cannot cross the road, these are the questions I directly ask. Or cannot drive, you know, these are the things telling me this needs to be treated. While some patients have, you know, a constant squint for years, and then they'll come with diplopia as a history, you know, it's something they're managing. They've already found a way to manage it. And so you may not need to be so aggressive in their treatment. Like they see double, but their daily activities are not affected, you know. they find the second image if they go looking for it, that sort of thing. So I'm not very aggressive with those. I'm not worried if I'm operating on those and I'm going to be dealing with some intractable diplopia. Well, those seem to be the long-standing ones. So it's good to get an idea about that. Of course, specific gaze, immediately we say right-sided, you think right-sided diplopia, you think of right lateral rectus palsy, Similarly, on a specific distance, if you have diplopia only for near, not for distance, you're thinking of convergence issues, you're thinking of accommodation issues. While diplopia only for distance, something like divergence. Then at the end of the day, very tired, that's when I see double. Otherwise, I'm not seeing double. Again, you're thinking of myasthenia. So uh, even in your examination, trying to differentiate your cranial nerve palsies, which come with diplopia, and other problems. I thought I'll just touch up on some of the external examination signs that take you through the differential diagnosis of diplopia. So if you've got ptosis, you're thinking of these conditions. Third nerve, myasthenia, CPEO. Of course, myasthenia doesn't have diplopia very often, but these are the conditions you'll think of. If you have lid signs, you're again thinking of Duane's, thyroid eye disease. These are what you're thinking of. Now, if you have limited adduction, again, partial third nerve, Duane syndrome, internuclear ophthalmoplegia, myasthenia. Myasthenia and thyroid is going to land up in all of these situations. Limited abduction on the other hand, again, Duane's and sixth has to be differentiated. Vertical movements, you need to differentiate between Brown syndrome and monocular elevation deficit. Brown's being worse only in adduction gaze, monocular elevation deficit, or otherwise called double elevator palsy, has limited movement. So you at least are thinking of these conditions when you're examining. Before you start examining, you get an idea of what you're trying to rule out. The other thing when you're looking at or differentiating a restrictive strabismus from a paralytic one, you have one clue, which is an easy clue, is that the angle that you measure of squint, if it is proportional with the level of underaction, then you're possibly dealing with a cranial nerve palsy, which means that if you've got a -3 abduction deficit in a sixth nerve, he'll have a significant esotropia. He will not have no esotropia. While a Duane syndrome with an abduction deficit of -4 will not have any esotropia, may not have any esotropia, or very small. Similarly, supranuclear palsies like horizontal gaze palsy or INO, they don't have squint in primary gaze. So if you have a discrepancy between the amount of movement and the level of squint, you have to suspect that this is not cranial nerve palsies. And again, they have secondary and primary deviations. Depending on which eye they're fixing, cranial nerve palsies can also be diagnosed based on that. Pupillary examination is affected in third nerve. Similarly, fundus, you're looking for causes of cranial nerve palsies like papilledema, diabetic retinopathy, because raised ICT can present with sixth nerve, diabetes can present with any cranial nerve, and pigmentary retinopathy if associated with CPEO. So these were the differentials that we went through that you need to look out for when you've got a patient of squint. Your first diagnosis will be to look for the three main cranial nerves, oculomotor, sixth and fourth, and then you have to keep all of these other in mind. Finally, one slide on what you would do. Of course, most commonly with cranial nerve palsies, we ask them to patch one eye and just to relieve the diplopia and wait for recovery if it's acute. But sometimes you've got small angles, especially up to 15 to 18 PD. You can prescribe prisms, especially if it's lasted long. So the rule is you get the measurement of the squint, and then you start with about half of that and put in the prism into the trial frame with their distance glasses on, make them sit outside your clinic for some time, get them used to that prism and see if they're happy with it. And you can go up to 2/3 of the measurement. So if you've measured, 15 prism diopters, I would, start with 6 or 7 and see how he's adjusting and go up to 10 maybe. Especially in exotropia, you may prescribe less because convergence helps in overcoming diplopia. So the rule is to always split the prisms. So if you've got 10 prism diopters, put 5 in each eye. When you've got horizontal squints, always it's placed in the same orientation. For exo, you'll put base out, and for ESO, you'll put base in. Oh, sorry, the reverse. And for hyper, it will be opposite in each eye. You want to be sure that if you've got a hypertropia in the right eye, you put base down in that eye, half the prism, and then the opposite in the other eye, that is base up in the opposite eye. So only in the vertical squints, the bases change, while in horizontal, they don't. Yes. So that's the end of this presentation. And I don't know where we are in terms of time.
Second is on diplopia.
So I thought we could take discussions going on from here. I think we had some delay. That would be a good idea. My second one was mainly I thought I would go through some common horizontal squints in children. I'm wondering whether going through the accommodative esotropias, just how to manage them and to detect them, and intermittent exotropia, because these are the two commonest things we're seeing all the time.
We have time. Please go ahead.
So I thought if we have a more interesting questions to still go through, maybe we should do that.
No, the thing is, this is something which a comprehensive ophthalmologist always we struggle with. So I would say these are common conditions. While we'll take them.
Okay.
And then we can go for the discussion. So we'll take maybe the 10 minutes we can do this, and then we start with the discussion.
Okay, so I'll just go through it in the form of cases.
Right.
So this is a case, and although I've just put all the examination and history just for a revision. I won't read those, but this is what you should do in every squint patient, going from complaints to prenatal history, family history, past history, medical history. But this is a child who's 5 years old, came with squinting convergent since the age of 1 year. And squint has been quite constant. She has unequal vision, as you can see. Unaided vision is unequal. Aided vision also is unequal. And when we did a cycloplegic refraction, we found that this child had a hypermetropia, which was not normal for a 5-year-old. And the other examination will come forward. So yes, we measured a 30 degree esotropia with also a slight DVD in the right eye. So we measured it in prism, so corneal reflex, then prism bar cover test. As the steps that we already discussed, we had a 50 prism diopter squint, and she looked like this, which this was a vertical, dissociated vertical deviation as well. We did some binocular testing, and she didn't have any binocularity. This is her vertical movements. She had equal squint for up, middle, and down, which meant she did not have any pattern. And so we went ahead and gave her glasses. She came back with glasses. Obviously, this is a situation where we are seeing esotropia and we're seeing hypermetropia. So we have to presume that this is an accommodative component. So the only way to know for sure is to prescribe the glasses and bring them back. And this is what we did for this child. We brought her back and we found that her squint significantly reduced to coming to be 8 to 12. And we also measured the AC by A ratio, which we'll talk about as we go ahead. So we diagnosed this patient as accommodative esotropia. Now, because this patient did not completely correct for distance and near, we labeled her as a partially accommodative esotropia. Okay. So what is the treatment of accommodative esotropia? Full cycloplegic correction. Now, I want to spend half a minute telling you that you will find these children having presenting around the age between 1 and 2 with a squint which is rather acute. It's just been there for a month or two, and you do a full cycloplegic correction, refraction, preferably with atropine for the first time, and then do not hesitate to prescribe the full plus. How much ever that is, children adapt very easily. Really, you will save time rather than going with a half power and then taking it beyond. Not required. Most of these children will settle in within a few weeks. Some of them, if they don't settle, you can give a cycloplegic drop like homatropine for a few weeks at home. So this was the point I wanted to drive home with this: prescribe full cycloplegic correction at the outset. So of course, once we've seen this patient back, we found vision was 6.9, 6.6, and the angle was not big, so we left it there. But in partially accommodative esotropes, this is the girl. If the squint is large enough, we would then get back and do a surgery for the remaining amount. So a little discussion about how accommodative esotrope goes. Essentially, you think of the etiology of it. It's a child that um, has a refractive error, say, of +3. Okay. And if we calculate his AC by A ratio to be normal, which is 5:1, so when he looks at a distance without his glasses, he has to accommodate worth 3 diopters. When he's accommodating worth 3 diopters, that is accommodation, the denominator, the amount of convergence will be 5 times that. That means for distance, he needs to converge. He will be converging 15 prism diopters. And for reading, he'll have to converge another 3, another 15. So imagine he has to converge with 30 prism diopters because he has an uncorrected hypertropia. And if they have some fusional divergence weakness, they will go into squint. So this is the basic understanding of accommodative esotropes, which is why a full cycloplegic refraction, manage the amblyopia. You may sometimes have to give atropine to relax accommodation, and surgery is done only for the residual esotropia. Now, let me take you to accommodation occurring, but there is no hypermetropia. So if you find patient
I think we've lost him. Can the others hear?
No, ma'am.
No, he has got disconnected, looks like.
Okay. So maybe we want to take another question in the meantime. So I would actually like to take this question, which has come from the audience, about how to deal with post-operative intractable diplopia. Dr. Rinkel or anyone wants to take that up?
Dr. Rinkel? Yeah. How to intractable. So if you can mention
Post-operative.
post-operative, which one? I mean, cataract
Post-operative.
surgery usually we don't have, but say maybe detachment surgeries or any other intractable
Squint
diplopia.
surgery.
Yeah.
One most important thing here is, like, if you are dealing with a patient, with an adult patient with a long-standing strabismus, say an exotropia, you need to make sure that correcting that long-standing exotropia, whether it is going to give him diplopia also. So prism adaptation test, like we say that you should give him a trial of prisms in office itself, and see whether with those corrected prisms, whether the patient is having diplopia. Those are cases like you would be like wary of operating, because after correcting the angle, the patient might be having diplopia, because he was able to suppress his images alternately very well because of a large angle squint. And now when you have like taken care of the squint, he is not able to do it so fluently. So such are the cases you should be wary of operating. And in case like intractable diplopias after surgeries, these are mainly seen in such cases only. And also in cases of trauma, if there was history of trauma, there is something called as horror fusionis. wherein the patient gets diplopia after surgery and he is just not able to fuse. So such cases, if you have corrected the squint, these patients will land up into that intractable diplopia. And in such cases, like there is no other, the other measures don't work so well, you have to do occlusion, or you have to give patient occlusive like an opaque contact lenses. In such cases, like cosmetic contact lenses can be given. And if the intractable diplopia is just because of overcorrection or undercorrection, you have to just treat it accordingly.
Correct.
Nice points. The next question. Now, suppose, Dr. Nikhil, if it's post-detachment, sometimes particularly scleral buckling surgeries, sometimes they have diplopia. So how long do you wait, or do you advise them to release the buckle if it is encroaching, or you wait for some time, or do you ask them to operate immediately?
No, generally, waiting for some time will not improve the situation at all. And most of the time, more often than not, it is that the muscle is probably being infringed upon, or it, pressurized upon or compressed with the buckle. So it has to be released at the earliest. Again, you wait more, the muscle goes into fibrosis, everything else becomes difficult. So I would definitely say, I mean, you have to take, you have to have the balance, the detachment recurring versus the diplopia reducing. So you have to have a balance of it, but at the earliest, I would say.
All right, fair enough. You want to take the next question, Pooja?
Yeah. What is the latest trend in management of amblyopia and squint patients?
Dr. Vadimbe.
Yeah, Dr. Prasad?
Boss of amblyopia is Dr. Vadimbe. Sir, please.
Of course. Am I audible again?
Yes.
Yeah. In fact, there are so many new treatments in amblyopia have come. Like, see, the dioptric treatments have come. So many new things have come. The binocular treatment come because our understanding of amblyopia has definitely evolved. But I would still say that still the gold standard is patching and patching, because the effect of patching far far better than the other treatments. Of course, there are some subset of patients, for example, those who are resistant to patching, those who are do not improve with patching. In some of the, even in adult patients also, the dioptric treatments have definitely shown a good results. In fact, many of my studies, our studies have shown that definitely there is improvement in vision as well as stereopsis. So the brain brakes can be lifted even at the age after the ambulogenic age. So some new treatments have definitely come. Of course, this is beyond the scope of this our webinar. But yes, the science is evolving, our concepts are evolving, and the pattern is shifting from the uniocular patching to the binocular treatment. But my personal choice still is patching as a gold standard. And if it doesn't work, then of course I go for that.
Dr. Vaishbari?
And one more addition, sorry to interrupt, but
No,
one
no,
more
no.
addition to what Dr. Wrinkle said, about the horror fusionist, or what we call as a fusion disruption, how we can diagnose it clinically. When you neutralize the angle, you'll see the characteristic bobbing movement, vertical bobbing movement. That's a typical of the horror fusionist, or the what we call as a central fusion disruption. Typically, we see in traumatic patients or the head injury patients, or sometimes in oblique pulses also we do see. The treatment, best what you can do the squint correction, preferably with the adjustables, and usually the results are not that good. So we have to definitely tell the patient that the diplopia will be there, but we will try to reduce the diplopia to the minimum possible. And we usually tell the patient to ignore that blurry image. But the treatment, even after treatment in horror fusion, is the diplopia still persists.
Absolutely. And Dr. Vaishbari, you are muted, so if you can just unmute yourself.
Yeah.
Which is, sometimes some adults, they are amblyopic and they say, can we do something? And we say, yes, now treatment is available. So how do you counsel them further? Because they are not going to get the same fast benefits as you get with younger children. So how do you counsel them? What do you tell them?
So for adult patient, we tell them, like, we give trial and not actually the results for amblyopic patient. Now for adult, we are using orthoptic treatments like orthoptic, which is made by Dr. Santan Gopal. That is giving good results in adult patient, also in amblyopic patients. And dioptics like red green glasses with some say app or some games on mobile, they are also helping to some extent, but not to the full.
And how
So
much time does it take? What do you tell them? How much time will it take? It depends on the degree also. I agree with that. How dense the amblyopia is.
Most of the time we give trial for say 3 to 6 months. If it shows at least 1 or 2 later improvement, then we'll continue the treatment. Same.
Yeah, because they
Have
do
you all
want
used
some time
the
frame.
Binox treatment? Have you all used it?
Yeah.
Anybody's using?
In
What is your
adult.
experience with that? Yeah, in adults.
In Binox, some patients do very good with small angle squint or say post paralytic squint or say neglected say lot of hypermetropic patients. They are not used glasses in their early childhood, and they come up with some say UPSC exam and on. They find out that their vision is low in one eye. In that cases, with glasses with dioptic, they showed some improvement.
Okay. What's
Can I
your
take this question?
experience? Sorry?
Yes.
Can I take? In
Yes,
fact,
of course. I was going to ask
Please,
you.
please.
That's true. Yeah. Please.
yeah, regarding Binox or dioptic treatment in adults, in fact, I have presented one paper in APSCRS this year only. And in fact, I have done a lot of patients on Binox. And after doing so many treatments with so many small children, adults, now I have come to the conclusion, yes, it does help. But of course, as the company claims, the visual improvement is not very magical. You won't see some 4 lines, 5 lines improvement. You might see 1 or 2 line improvement definitely. And in fact, I have tried in all patients many of the times because squint, strabismic amblyopia, stimulation deprivation, so many things I have tried. And what I have found it usually works in usually the refractive amblyopias only, that is anisometropic, meridional, and ametropic amblyopia. In other types of amblyopia, it doesn't work. Along with vision improvement, you will see a marginal improvement in stereopsis also. The contrast sensitivity, although the improvement is definitely seen on the values, but it is not statistically significant. These were my observations. So the take-home message in typical types of, say, anisometropic, meridional, or ametropic, it does help. The visual improvement is there, which is statistically significant, but it is not very good. Not very good means not 2 lines, 3 lines, or what usually the claims are there. So that's my observation.
Nice.
Dr. Valambe, I just have a question.
Yeah.
For these adult amblyops that you would have tried Binox on, were these untreated in childhood, like no patching done?
Both. Some of the patients were treated, some of the patients were not treated. And in fact, these are the parents of my amblyopic children. So in fact, one of the parent only asked me, can I try it? So I said, you have nothing to lose. So at most, what will happen? The vision will remain the same. So that's how I tried doing it. So I have the maximum follow-up up to 2 years now, almost 3 years now. So they have maintained the vision till 2 years. What will happen after 5 years? I don't know. Maybe we should be able to discuss it after 2 years. So after now, they have maintained the vision.
Okay.
But of course, the visual improvement is not very grand or not very, as I told. It is statistically significant. And also, interestingly, the stereopsis also has improved, which is statistically significant, but it is not very high as the claims are there.
Next question you want to take, Puchu?
So I think 2 questions which are important is when to operate a child with a very small degree of a squint, and if we have to also operate a squint, what is the angle that we should follow while we are deciding to operate a squint?
The measurement, right? That's
the
what
measurement.
the
Yes, measurement.
Dr. Ashwin, you can also give you. You're muted actually, so if you can just unmute yourself.
So a small degree of squint will again depend upon, whether the children, at least with small degree of squint, maybe after you have operated and you have not got the full correction and you've got a little bit left. That's probably the commonest situation where you will get a small degree. Otherwise, getting primarily a small degree is not so common. So small degree, I will always first try and give prisms and see how I can build up the patient binocularity and vision. And then if I know that I am gaining some binocularity, then you can do a single muscle surgery. So I will be quite conservative when small angles come into play. I will go through the conservative steps first, and then once I know that I'm creating some, sensory stimulation and I have got some binocularity, then it would be worth stepping in with a surgery.
So I think it's surgery
And
calculator.
if it's already done surgery and you've got a little bit left, then again I would put them on prisms, build them up, and then think of again doing the one more muscle there. There is some in the beginning when I come back from my fellowship, I used to do Botox for these residual squints because wherever I had worked with someone who did a lot of Botox. He almost did about 30 patients of Botox in a week. So that was his. So I did quite a few Botoxes, but unless they don't have a good, binocularity, they will not, stay there. They will, in fact, get doses, and you're dealing with many years. So I'm doing it very less now.
So the next question, is there a Squint surgery calculator available, Dr. Nikhil, for you with surgeon's correction factors? That's one of the questions that has been asked.
Yeah,
So it is there.
there is an
You can buy a
AO.
surgeon only directly.
Yeah.
Sorry?
So you can directly buy a
Bias.
surgeon only
Yeah, you can buy that, yes, but this is the
instead
question.
of.
So
No, there is an AO table or guideline that is available. And let me assure you that there is no standard measurement or measure for any squint surgeon or squint surgery.
Okay.
There's going to be at least a 10 to 15% variability because everyone handles a muscle differently. Everyone will get different correction per millimeter. So that can be barely a guideline. So the more you do, the better you understand how much you're getting out of it. And I think that you have to calculate from case number one. So my case number one was so and so, out of which I got this much, for which I had done this much. And then when you analyze, you create your own table. So AO guidelines, or I would just say Dr. Pradeep Sharma is the best for me. He's like the mentor that he's mentored me, and he's the best. So I think there is a table in his book as well, Dr. Pradeep Sharma. I would follow that any day over AO. And but that is like the best guideline one can have. One has to devise their own measurements and understand the principles. For example, I would just quickly touch upon the micro isotropias and micro exotropias that were discussed before this. So, like Dr. Ashwin said, in single muscle surgeries and all, you have to understand how much correction you're going to get at different ages. For example, a single muscle at 6-month-old child age is going to give us probably 5 prism correction in an isotropia per millimeter. And the same at the age of 15 is barely going to give us 1.5. So you have to understand how it works and so important it is. And for lesser amount of deviations, please, resections are not to be taken up. They have to be recessions because those are reversible, if at all.
Nice tips. So basically, there is no one formula.
No.
That's what you're trying to say.
Yeah.
It depends upon the age and so many other factors, and you devise your own.
Everyone's like in our fellowship programs at HVDSI, I used to see that every fellow has his own sort of a different calculation, and we used to discuss it.
Okay.
So this is what you're getting per thing. So calculate it, and I will probably get more. You will probably get lesser. It's also about how you're tying your knots, how much you're tying your knots, all of that. That is a lot of variability.
I agree. Because the AO guidelines or Dr. Sharma's guidelines, these are basically the guidelines on which you yourself can build.
Yeah.
And what I feel, the squint is like a mathematics. The same problem can be solved in many ways.
Right.
So if I do say for example, for a 35 prism diopters of esotropia, I might do 5/7, that is 5 millimeter precision and 7 millimeter. Nikhil might do 5.5. So after doing many cases, you yourself come to know after doing this much how much correction I have.
Correct.
So you have the basic guidelines on which you can build. That's the
It's
basic take-home
it's the
message.
same like a trabeculectomy. Each
Yes,
surgeon
yes,
has its own thing.
absolutely.
The
Yeah.
underlying procedure is the same, but
Same.
you add your own nuances and you get different results.
Yeah.
So very nice tips.
Absolutely.
Dr. Wrinkle, what is the least age? One of the question is that which is the least age for minimum age for squint surgery? So for you, I'm also going to ask Dr. Vaijwade. So Dr. Wrinkle first here.
So least age at which you can operate for a squint. For an infantile ET, it is supposed to be between 6 to 12 months of age. Because that is the golden period when you are able to salvage a little bit of like whatever like stereo acuity you might salvage in that case. And be below 6 months of age, as we know, the fixation is not so well developed many a times in because we get so many of premature babies these days. So 6 months of age, 6 to 12 months of age, is the age which is the least age which is described.
Yeah.
So how easy is it to convince a parent to get the child operated at 12 months? Because typically the thing is, nahi touch karo. That's how it is. So Dr. Vaishwade, how would you convince? How common is it for people to agree, for parents to agree to such?
Most of the time they don't agree, ma'am. Yeah,
True,
so
exactly.
yeah. And we also think anesthesia is parents' mentality and what child is going to get after that. Because most of the times, child may need another surgery in near future. So that's why uh, we call the patient for at least 2 or 3 sittings for get an accurate measurement. If the measurement of 2 sitting is less than 10 prism diopter, then only we go for the surgery. And just for completion of last question, there is one Squint Master is available on internet from Dr. Sudhir Singh from AIMS, where you can just feed the amount, say like 40 prism or 50 prism, whatever you get, and that master will tell you how much to recess and resect. That is online, and definitely those who are doing squint surgery, they will rely on their previous results, and we are still modifying our charts for say 30 diopter prism, how much to resect and resect. Yeah.
So thank you for those tips. Anything else, Pooja?
I think one good question would be what is the management of an alternate squint in an adult which has binocular vision of 6 by 6? So both eyes have 6 by 6 vision and we have an alternate squint. So I think Dr. Wrinkle actually touched upon long-standing adult strabismus, which is having good vision in both eyes and is 6 by 6. But if you had to tackle those patients, you may not want to go in for the full angle, or you want to give them the prism adaptation test before you go in and correct them. Is there something else that you'll want to take up on that?
It's an alternative squint.
It's an alternating squint. That's why the vision is also equal and good in both the eyes. And this is an adult. So they have probably a large suppression scotoma that has set in. And then we are going to correct them.
Sometimes they do come that all this life, sometimes they have issues with the squint. Like people look at them and they see the
Confidence.
squint, the confidence level. So they want to get the squint done, but you have to tell them the other thing. So how would you go about it, Dr. Nikhil?
I think the first thing is even if it's an alternative squint and both eyes squint very frequently and alternately with equal dominance, for a similar squint in childhood, we would do bilateral recessions. I would do bilateral recessions because the muscles are stronger, hence the weakening will be better. As you become an adult, the recession is going to be very ineffective according to me. So I would never do bilateral squint surgeries. For example, if it's exotropia of 40 prisms, bilateral atelectasis recessions in my hands have never worked, or rather I've never done that. It's always going to be a recess resect in one eye. And then, of course, the neuroadaptation, and the other eye squint also goes. And absolutely we tell them ki for a 3 days or a 4 days, 2 days, 3 days, you might have intermittent diplopia. So do not embark on two-wheeler riding or cars, and be careful crossing the streets and all of that. But generally, if you have gotten it within fusible range correction, that fusible range also is different for convergence and divergence. We know that even in adulthood, then the risk of intractable diplopia is much lesser. So I would always do just one eye. I am sadly or unfortunately or fortunately not a big proponent of adjustable sutures because I was never trained in it. So I never had that option. I don't have that option. So I try to make it whatever works best, and one eye will generally work. People have said that 60 prism, 50 prisms correction does not happen in two extraocular muscle surgeries in one eye. I have seen up to 70 prism, 75, 72, 70 prism corrections with one eye, because the resection and how you tie the knots is going to change the correction per millimeter at the same age of an adult. So if you tighten it more, you will get 5 to 10 prism more correction, in my experience. I think the seniors can contribute here.
So Dr. Nikhil has one type of experience. What about you, Dr. Vadimbe? Do you counsel them that, okay, you may require a surgery, a second surgery once we assess how the one eye surgery has gone? What is the residual squint? Do you counsel them like that, or you would do 3 muscles?
Yes. No, I won't do as Nikhil does. I usually don't do 3 muscles in one sitting. And they typically, what I tell the patients, it might require more than 2 surgeries. We'll try to do it in either 1 or 2 surgeries.
Dr. Sharma says that as well. वैसे तो तीन सर्जरीज लग जाएंगे, मैं कोशिश करता हूँ कि 2 सर्जरीज में कर दूं. And of course he gets it right in one surgery.
And regarding the previous question of the earliest age and how to counsel the patients, because most of the times, these are very small kids. So I usually never tell them the squint surgery in the first visit. Of course, you do require more than 2 visits to accurately assess what is the angle of squint. And especially if you know the infantile ETs, their kids are sometimes cranky, you might get at best some idea of the angle of squint. You cannot measure like it's a 42 prism diopters or 38 prism diopters. It might be between 30 to 35. That's best what you can do. So you do require more than 2 visits to exactly assess how much is the deviation. You also develop that rapport also. You also tell about what are the evidence-based guidelines. I encourage them to read about it also, because most of them are quite educated parents, and we take the decision. Parents as well as me, both of us take the decision. It's a joint decision. Yeah. And of course, the baby has to be fit for the surgery also, because the life takes precedence over the eyes. So when the baby is fit for surgery, then only I advise the surgery. So we have to take the fitness from the pediatrician. So these are some practical guidelines.
Before we take the next question, just a 1-minute video from Ajanta. Manjula, if you can please play that video. Manjula?
Sure, doctor. Sure, doctor.
Please. In the meanwhile, Pooja just will... Yeah. Welcome back, Pooja. We've covered all the questions, or is there?
Yes, I think we've covered most of them. There are maybe just 1 or 2, but I think we can just take it in a very simple show of hands. There is one question about most common approach to IDS. So in intermittent divergent squint, how many of us are using over minus glasses as a form of therapy or control to improve?
Okay, Wrinkle says no. Dr. Wrinkle says no. Dr.
No.
Prasad is also saying no. Dr.
No.
Ashwin also is saying no. Okay.
Yes,
So
because
I
there was a recent study where they noted that actually getting true myopia. So I think it's better. It used to be a practice of the past, which is
Yes.
not encouraged anymore. How many use alternate eye patching to control intermittent divergent squint
I
control?
don't know.
Selected patients. Selected. Very selected patients.
Yeah. So Dr. Ashwin is saying no. Wrinkle is saying no. Dr. Prasad, he's saying in very selected. So which ones?
Especially, the angle is small sometimes, and then the amount of deviation is less. In the subsequent visits, the patient is not deteriorating because all these things, if we find, the mode of treatment would be surgery. So it has to be very selective.
So I'll ask the
Okay.
any more Pooja?
Yeah, there's one more. Is anyone
Yeah.
using the Binox protocol to improve the control of the squint or using any software to improve the binocular fusion in these patients for IDS?
So yeah, I have been using in patients, especially those who are not ready for surgery and want to postpone or buy time, and also in patients who've had surgery and have had some undercorrection, and still I want to, maintain their binocularity for longer before I can convince them for one more surgery. So more of a a delay, uh, postponement of the inevitable.
I have
Yes.
used it in some of the patients, but the results were not that encouraging.
So one question, if in a comprehensive ophthalmologist clinic, what is the must-have instruments they should have to
Retinoscope.
evaluate? One is retinoscope, all right.
And it's a rarity. It's a rare commodity, let me tell you.
Are you saying that?
Yeah.
Achha, retinoscope
Very
is
rare
not there?
commodity. Yeah, hardly anyone's doing retinoscopy nowadays.
But having the retinoscope does nothing.
Actually, you use them, right?
Should use it also.
It's just like glaucoma. They work if they use it. So, okay. So one
Loose
retinoscope.
prisms. I think
Uh,
loose prisms.
Yeah, yeah.
Which one?
I
Sorry?
think
Prisms.
occluder.
Loose
Just learn to
prisms.
do proper cover test. Occluder.
Okay. Occluder, which we all
Then
have.
Just to do
occluder,
cover test.
And
yes.
Cover
retinoscope,
test.
then
A Spillman occluder is like a good must-have.
Yeah, Spielman's
Alright.
is
And
once used.
accommodative target stick, like if you are having that, that's a good must-have.
Okay. Loose
And
prisms. What else? Any of these binocular testing, like say, Dr. Ashwin, he showed at least 4 things which we use
Yeah.
to check the binocular vision. So should they have that also?
I think they have
TNO is preferable.
TNO? Yeah. And how much does that cost, TNO?
32,000.
32,000.
32.
Okay. So the loose prisms instead of a prism bar, is that what you're suggesting?
Yeah.
Loose prisms. All right. So these are the must-haves: retinoscope and use them, occluder and use them, of course. Then you have these binocular tests and loose prisms. And
And
for
the
diplopia
accommodative
charting,
target, which Dr. Inkle said also,
yes,
ma'am.
yes,
Because a lot of people will do the squint
On
assessment
torchlight.
on a torchlight.
Yeah.
Setting up a pediatric ophthalmology clinic or setting up is the cheapest thing. What is more important is, having the time and interest to attend a session like today is probably the first step. And then you automatically, feel encouraged to get that one instrument or two, you can just get it. So just the knowledge of just doing that cover test and, treating that refractive accommodative squint correctly, that just those basic ones should be incorporated in every general ophthalmologist's practice, I feel.
red-green glasses. And what is the target when you are using the diplopia charting? When we were residents, we used to, on the torch, we used to put a patch with a vertical slit. That's what we used to do. So is there anything else that you would suggest? You also said a streak retinoscope.
Retinoscope we can use.
I think that's the
All
easy.
right. So not very expensive. I mean, definitely not as expensive as an OCT or a perimeter. It is basically, as Dr. Ashwin said, the inclination to do things properly. So I think that was a wonderful webinar. Pooja, any more questions?
No, ma'am, I think we should.
Yeah. So Dr. Ashwin gave a fabulous and very practical, practical lecture. I mean, I learned so much. I had forgotten Squint, and I had a wonderful co-moderator, Pooja, and Dr. Wrinkle, Dr. Nikhil, Dr. Prasad Valimbe, Dr. Vaijuvade. They were amazing in their tips. So I'm very grateful to all of them. And so I thank all of you, of course, Numerotech, because of this, because how they manage the whole interface. Thank you, Manjula, and Ajanta Pharma for being sponsors to this entire series, and Dr. Anaga Herur, who has conceptualized.
Lovely webinar and great discussion, must say. Yeah.
So
thank you so much, everyone.
Thank you, everybody. Till we meet again, and have a good night.
Thank you.
Thank you, Dr. Preeti,
Thank
Dr. Pooja, and all the other panelists.
Thank you.
It's lovely to be here.
Thank you, Dr. Preeti. Thank you. Thanks a lot for giving me this opportunity.
Oh, we enjoyed it.
And I apologize for all the, problems that I had with.
But that happens, and we had a good lecture. Wonderful lecture, I would say.
It was wonderful. Yeah.
Thank you so much.
Wonderful.
Bye-bye. Good night.
Thank you, ma'am, and thank you, everyone.
Thank
you.
Good night.